We're going to get started this afternoon with a presentation on diabetes by Stephanie Luon, entitled Hindsight is 2020, Complex Type 2 Diabetes Management. Steph is currently the supervisor of ambulatory clinical pharmacy services and the PGY2 Ambulatory Care Pharmacy Residency Program Director at Yale New Haven Hospital, and she practices in the Yale Adult Cystic Fibrosis Clinic. Board certified in ambulatory care pharmacy and pharmacotherapy, Steph also serves as the legislative chair of CSHP and is a member of the Ambulatory Care Practice Advancement Initiative Section Advisory Group for the American Society of Health System Pharmacists. Additionally, she serves as the new practitioner mentor for the American Pharmacists Association Academy of Student Pharmacists chapter at the UConn School of Pharmacy. Steph, the floor is yours.
So thank you, Nathan, for that introduction. Okay, I have no relevant financial relationships with any commercial interest to disclose. For our agenda today, we're going to review the pathophysiology and epidemiology of type 2 diabetes and its impact on chronic kidney disease, as well as cardiovascular disease. We'll identify information pertinent to management of patients with type 2 diabetes and concomitant CKD and/or cardiovascular disease within the 2021 ADA Standards of Medical Care and Diabetes Guidelines and the 2020 Kidney Disease Improving Global Outcomes, or KDIGO, Diabetes Management in CKD Guidelines. We'll examine emerging literature investigating the use of SGLT2 inhibitors and GLP-1 inhibitors, GLP-1 agonists. Utilize evidence-based medicine to appropriately manage a patient with complex type 2 diabetes, and then explore the impact of the COVID-19 pandemic on the care of patients with type 2 diabetes. So we're going to jump right in with a pre-assessment quiz. And so according to the National Diabetes Statistics Report published in 2020 by the CDC, what is the prevalence of diabetes in the United States? And for those of you who listened to our keynote speaker yesterday, she actually shared this figure in her presentation as well. Okay, so it looks like nobody picked 2.5% or 5.5%, which is great. 10.5%, we had about 44% of participants, and 15.5%, about 56%. So the correct answer is 10.5% of patients. Our next pre-assessment question is, what is the mechanism of action of an SGLT2 inhibitor? A, inhibition of sodium glucose cotransporter 2 in the proximal renal tubules, which leads to reduced reabsorption of glucose and increased excretion in the urine. B, increased liver and muscle sensitivity to insulin, decreased hepatic glucose output, decreased insulin resistance, and decreased LDL through increase in fatty acid oxidation, activating PPAR gamma, leading to enhanced glucose and lipid metabolism, increased sodium reabsorption in the renal tubules, and increased insulin sensitivity. Or D, increases glucose-dependent insulin and amylin secretion, decreases glucagon, decreases gastric emptying, and increases satiety. Okay, looks like the 63% have it with inhibition of sodium glucose cotransporter 2 in the proximal renal tubules, which leads to reduced reabsorption of glucose and increased excretion into the urine. Option B, I'm glad that no one selected it because that is the mechanism of action of metformin. Option C is the mechanism of action of oh goodness, we'll go back to that one. D is the GLP-1 agonist, and C is the thiazolidine dione. There we go. Okay, polling question 3. The following benefits are benefits of the use of SGLT2 inhibitors, except A, reduced risk of urinary tract infections, B, reduction in albuminuria and progression of CKD, C, reduction in risk of hospitalization in patients with heart failure, and D, reduction in A1C. And the A's have it. So we know that increased risk of urinary tract infections is a side effect associated with SGLT2 inhibitors, because if we think back to the last question about its mechanism of action, we're causing more glucose to be excreted in the urine, and therefore glucose and sugar can be a breeding ground for bacteria, leading to an increased risk of urinary tract infections. It's a great job. Question number 4, which of the following is preferred therapy for patients with a diagnosis of type 2 diabetes with an A1C less than 9% and concomitant CKD with an eGFR greater than or equal to 30 mLs per minute, according to the 2021 ADA and 2020 KDIGO diabetes management and CKD guidelines? A, metformin and a sulfonylurea. B, metformin and an SGLT2 inhibitor or metformin with the GLP-1 receptor antagonist. C, metformin and a thiazolidinedione, or D, metformin and insulin. Excellent, 100% got it right. Okay, so our last pre-assessment question is, how did the COVID-19 pandemic influence the care of patients with type 2 diabetes? A, it increased demand for telehealth and novel healthcare delivery options. B, increased the number of patients with food insecurity. C, it disrupted established exercise routines. Or D, all of the above. Perfect, another 100% correct response. D, all of the above. So next we're going to jump right into our patient case. So LS is a 55-year-old male and he presents to pharmacy clinic for diabetes management. His past medical history includes uncontrolled type 2 diabetes, obesity, heart failure with reduced ejection fraction with an LVEF of 40%, and hyperlipidemia. His current medications include baby aspirin once a day, atorvastatin 40 milligrams daily, vitamin B12 1,000 micrograms daily, lisinopril 5 milligrams daily, furosemide 10 milligrams daily, metformin 1,000 milligrams twice daily, metoprolol succinate 100 milligrams daily, and a multivitamin tablet daily. He's had no medication changes in the past 4 months, and his A1C goal is less than 7%. So these are his vitals, nothing too out of the ordinary. BMI is elevated as he is obese. For labs, I've highlighted those that are pertinent and out of range. So as you can see, starting on the right, from 6 months prior to the visit, his A1C was 9.5, and moving towards the left 3 months prior to the visit and to 1 week prior to our visit. It's slowly trending down, but it's still not at our goal of less than 7%, which we'd like to see. We can see that he does have some renal impairment with an elevated serum creatinine and a decreased eGFR. His fasting glucose is also quite elevated. You can also see that his urine microalbumin creatinine ratio is also elevated, signifying that there's some albuminuria. So now let's take a little look at epidemiology of diabetes. So the 2020 CDC National Diabetes Statistics Report that includes data from 2016 to 2018 demonstrated that 34.1 million adults, or 13% of all adults in the US, had diabetes. 7.3 million adults who met laboratory criteria for diabetes were undiagnosed, which means that almost 3% of all adults and 21.4% of all adults with diabetes were undiagnosed. An estimated 88 million of adults had prediabetes. More than 60,000 people die of heart disease each year. 37% of patients with diabetes had CKD, and more than half of these patients, 52.5%, had moderate to severe kidney disease. So you can see that our patient case is not necessarily uncommon. Diabetes is the leading cause of new cases of blindness among adults aged 18 to 64. And in 2017, diabetes was the 7th leading cause of death. I think you can see that these are some pretty concerning statistics. And pharmacists can do a lot to help. So a very brief overview of the pathophysiology of diabetes. For type 1 diabetes, we know that it's an autoimmune destruction of the pancreatic beta islet cells that are producing insulin. So that leads to insulin deficiency. In type 2 diabetes, we see more insulin resistance or insufficient insulin being produced. This is kind of a nice figure that I like that shows a lot of the different manifestations of type 2 diabetes in the body. So we see excessive glucose production in the liver, increased lipid storage. In the adipose tissue, we see the same increased lipid storage as well as inflammation. In the brain, we see impaired activation of satiety centers, central insulin resistance. In the muscle, we see impaired glucose uptake, impaired glucose storage and metabolism. In the gut, we see impaired incretin effect, and we know that incretin is our hormone that's released from our pancreatic beta cells that promote secretion of insulin, and amylin, which slows gastric emptying and promotes satiety. So that's really important in our patients with type 2 diabetes. It also causes a change in the microbiome composition. In the pancreas, it impairs insulin secretion and loss of beta cell mass. There's excessive glucagon secretion, impaired incretin effect. In the kidney, we have increased glucose reabsorption and increased gluconeogenesis. And so you can see there's so many different manifestations of type 2 diabetes, and that's really why we're able to have so many medication therapies that can target different areas. So how do we diagnose diabetes? This is the criteria for how to diagnose diabetes from the American Diabetes Association. And for the first 3 criteria, in the absence of unequivocal hyperglycemia, a diagnosis does require 2 abnormal test results from the same sample or in 2 separate samples. So for our first criteria, you need a fasting plasma glucose of 126 milligrams per deciliter, and fasting is defined as no caloric intake for at least 8 hours. You can have a 2-hour plasma glucose 200 milligram per deciliter during OGTT. So this test should be performed as described by the World Health Organization using a glucose load containing the equivalent of 75 grams of anhydrous glucose dissolved in water. I've personally not taken an OGTT, but I've heard that it is relatively gloppy and not the most pleasant thing to imbibe. You can have an A1C of 6.5%, and the test needs to be performed in a certain type of laboratory. Or with a single test in a patient with classic symptoms of hyperglycemia or hyperglycemic crisis, a random plasma glucose of 200 milligrams per deciliter is enough to be a diagnosis for diabetes. So here's a knowledge check. Which of the following criteria yields a definitive diagnosis for diabetes? Can we get our next poll to pop up? A, fasting plasma glucose 126 milligrams per deciliter, the 2-hour OGTT with 200 milligrams of plasma glucose, an A1C of at least 6.5%, or D, in a patient with classic symptoms of hyperglycemia or hypoglycemic crisis, a random plasma glucose of 200 milligrams per deciliter. And this one might be a little tricky. Okay, excellent. So the 44% majority got it right. So this is the only criteria that can give a definitive diagnosis of diabetes without either being repeated or having more than one of the criteria being met. So next we're moving on to complications of uncontrolled diabetes. So if type 2 diabetes is left untreated, patients can unfortunately progress to having macrovascular and microvascular complications. And this is really why we care about treating type 2 diabetes. Patients might say, well, my blood sugar is a little bit elevated. I don't really notice. It's not affecting my life too much. Why do I have to take all of these medication therapies? Why is this so important for me? And it's really because we need to prevent these macrovascular and microvascular complications to prevent the patient from suffering later on in life or even not surviving as long as they would normally. So for macrovascular complications, we have coronary artery disease, which can lead to an MI, cerebrovascular disease, which can lead to stroke, or atherosclerosis, or narrowing of the arteries. For microvascular complications, we see diabetic retinopathy, which is responsible for about 10,000 new cases of blindness each year in the US that I had reported on the epidemiology slide. Diabetic nephropathy, or CKD, and it's the leading cause of renal failure in the US. And so the definition is really proteinuria more than 500 milligrams in 24 hours in patients with diabetes. And then the third microvascular complication that we see is diabetic neuropathy. So patients who have signs or symptoms of peripheral nerve damage when they have diabetes. And so that's the tingling or numbness in their extremities, and why it's so important for us to perform foot exams on our patients with diabetes, or have them see a podiatrist to make sure that they are not experiencing neuropathy. Retinopathy is the reason why we have our patients as a standard of care get their eyes checked annually for an eye exam. So next we'll jump into pertinent guidelines. And so for the course of today's discussion, we're really going to focus on complex patients with type 2 diabetes who have either a cardiovascular complication or or chronic kidney disease. So today I'm going to share the 2021 ADA Standards of Medical Care in Diabetes and the 2020 KDIGO Diabetes Management and CKD Guidelines. So this, I realize, is a very small picture. We are going to zoom in, but I wanted to kind of give you an overview of this is the document that you're really looking for in the ADA guidelines if you want to see their recommendations, use their algorithms to best treat your patients with type 2 diabetes. I will call your attention to this first line, which again, I know is really hard to see, but it does say that first line therapy is metformin and comprehensive lifestyle changes, including weight management and physical activity for all patients, regardless of what their risk factors are. Of course, if they have renal function that's not appropriate for metformin, then we wouldn't start metformin in them, but for all of their patients, unless they have a reason not to. It's our first line. So next, I want to highlight what we're going to focus on today, and those are indicators of high risk or established ASCVD, CKD, or heart failure. So zoomed in, these guidelines are telling us that we need to consider independently a baseline A1C, individualized A1C target, or metformin use. And so this is very different than what we've seen in the past. In past years of ADA guidelines, they didn't necessarily say go to certain therapies first, or GLP-1s and SGLT2s first. It's really great that they have broken it down into if a patient has heart failure, particularly heart failure with a reduced ejection fraction, they recommend SGLT2 inhibitors with proven benefit in this patient population. For patients who have positive ASCVD indicators of high risk, so patients with established ASCVD, patients who are age greater than or equal to 55 years with coronary, carotid, or lower extremity artery stenosis of more than 50%, or LVH, then they would recommend either a GLP-1 receptor antagonist with a proven cardiovascular benefit, or an SGLT2 inhibitor with proven cardiovascular benefit. And so if the patient's A1C is above target, they really want us to, if we started the patient on a GLP-1 receptor agonist, they want us to consider adding an SGLT2 inhibitor. If we started a patient on an SGLT2 inhibitor, they want us to consider adding a GLP-1 RA. And then you can continue to advance to other therapies as you need to. So for patients with CKD, if the patient has diabetic kidney disease and albuminuria, so for patients who have that, as well as EGFR less than 60, patients who have DKD and albuminuria, preferably we would use an SGLT2 inhibitor in patients that it has primary evidence of reducing CKD progression. Or you could use an SGLT2 inhibitor with evidence of reducing CKD progression in the cardiovascular outcome trials, or a GLP-1 receptor agonist with proven CVD benefit if the SGLT2 is not tolerated or if it's contraindicated. So if we go down the path of we do not have diabetic kidney disease and albuminuria, so patients with type 2 diabetes with CKD, who are thus at increased risk of cardiovascular events, you can pick either one, a GLP-1 or an SGLT2. But if you have albuminuria, they recommend an SGLT2. This is another really great image that I liked from the KDIGO 2020 guideline. So all patients, we start at the bottom. So patients who have diabetes with CKD, they want to encourage exercise, nutrition, smoking cessation, lipid management, blood pressure control, and glycemic control. For most patients, they recommend RAS blockade, so usually with an ACE or an ARB, and then SGLT2 inhibitors. And in some patients, generally patients who are using antiplatelet therapy or aspirin for secondary prevention for established cardiovascular disease. It might also be considered for primary prevention if there's a high risk individual, and sometimes dual antiplatelet therapy is warranted. So the next chart that I thought was really helpful from the KDIGO 2020 guideline, this is very similar in their recommendations to what the ADA guidelines share. So lifestyle therapy is first, and then first line medication therapy, metformin if it's appropriate per the patient, and then an SGLT2 inhibitor as long as the patient's eGFR is greater than 30 and they're not on dialysis. And then second line becomes GLP-1 receptor agonist is preferred, and then other therapies based on patient preference, and also other factors like renal function. This is also a great chart that I really liked. It is a little bit small, but again, you have a copy of these slides that you can kind of zoom into, or you can pull up the KDIGO 2020 guidelines on your own. But for your reference, this circle shows, based on patient preference, comorbidity, or other characteristics, which medications would be most suitable and which medications would be less suitable. So for patients with high risk of ASCVD, they recommend GLP-1 receptor agonists. For patients with potent glucose lowering effects, that's the desired effect that we want, we have GLP-1 receptor agonists or insulin. For patients avoiding hypoglycemia, who want to avoid it, we have GLP-1 receptor agonists, DPP-4 inhibitors, TZDs, and AGIs. For patients who want to avoid injections, you can see that we have a lot of oral agents. For patients who are interested in weight loss, we have GLP-1 receptor agonists again. Patients interested in low cost, you can see we have sulfonylureas, TZDs, and AGIs. For patients who have eGFR less than 15 or are on dialysis, we have DPP-4s, insulin, or TZDs. So you can see for most of these comorbidities, unless a patient is wanting to avoid injections, has a barrier to cost that can't be overcome with foundation funding or copay cards, or patient with severe renal impairment, they pretty much always recommend a GLP-1. So now I want to jump into the mechanism of action of an SGLT2 inhibitor. So SGLT2 inhibitors, or sodium glucose cotransporter 2 inhibitors, inhibit glucose reabsorption in the proximal tubule via SGLT2, its main site, leading to increased urinary excretion by glucose. So we can see SGLT2 over here, and it's really broken and zoomed in down here. SGLT1 is over here. SGLT2 represents about 90% or more than 90% of glucose reabsorption back into the body. And SGLT1 represents less than 10%, but it still does have an effect. So you can see both of them kind of zoomed in, and we see that the renal reabsorption of glucose is really controlled by those receptors that co-transport sodium and glucose. SGLT2 is situated in the first section of the proximal convoluted tubule, and we really see that most of the sodium and glucose is reabsorbed back into the cell in that area. So it's helpful that SGLT2 targets preferentially this SGLT2 receptor rather than SGLT1. So when we're inhibiting SGLT2, we're inhibiting the glucose reabsorption. So more glucose is excreted into your urine and there's less in your bloodstream. It also, with glucose and sodium come water. So you also have water excreted in the urine, which is why there are some blood pressure lowering effects of SGLT2s as well. So this is a summary table of all of the cardiovascular and renal benefits outcome trials for SGLT2 inhibitors that are on the market in the US. So we have on the left-hand column, the clinical trials, the drug, the cardiovascular benefit, heart failure benefit, and renal benefit. So our first drug that we're going to look at is empagliflozin, and we saw a reduced risk of 3-point MACE, which is death from cardiovascular cause, non-fatal MI, and non-fatal stroke. For heart failure benefit, we saw a reduced risk of hospitalizations for heart failure, and renal benefit, we saw a decrease in eGFR. For canagliflozin, we saw an increased risk of 3-point MACE again. We saw a decrease in risk of hospitalizations for heart failure. And then we saw a decrease in the composite endpoint of ESRD. And in this study, that was dialysis, kidney transplantation, or a sustained reduction in eGFR less than 15 milliliters per minute, or doubling of serum creatinine level, or death from renal or cardiovascular causes. So quite the composite outcome, as well as decreased progression of albuminuria. Dapagliflozin, we see a decreased risk of 3-point MACE, but it's not statistically significant. And then we see a decreased risk of hospitalizations for heart failure, as well as decrease in a composite endpoint of ESRD. And for that one, it was the Declare TIMI 58 trial that showed us this, and it was defined as greater than or equal to 40% decrease in estimated glomerular filtration rate to less than 60 milliliters per minute, or new end-stage renal disease, or death from renal or cardiovascular causes. So if we move to ertugliflozin, we can see that it demonstrated it was non-inferior to placebo for major adverse cardiovascular events. There was a decreased risk in hospitalizations for patients with CHF, and they didn't really report any renal outcomes. For sotagliflozin, there is a decreased risk of composite endpoint of death from cardiovascular causes, hospitalizations from heart failure, and urgent visits, and they didn't report renal benefits. So I bolded and turned blue those drugs that either have cardiovascular, heart failure, or renal benefits. So you can see empagliflozin, canagliflozin, and dapagliflozin might be our SGLT2 inhibitors of choice based on a patient's indication. So this is just a comprehensive slide of some of the cardiovascular and renal benefits of SGLT2 inhibitors, and I'll just highlight a few. So it helps to decrease age-mediating effects as well as age-range signaling, and this is kind of a signaling pathway that when patients have diabetes, it can be increased and it can lead to vascular calcification, which is not something that we want. They can help to decrease body mass. It can increase glycemic control, increase endothelial function, decrease blood pressure, decrease plasma volume, increase natriuresis and osmotic diuresis, increase glomerular afferent arteriolar vasoconstriction, which is a great thing because we want to be able to not damage our kidneys, as well as increase glycosuria, so more glucose in the urine, which makes sense with our mechanism of action, as well as decrease albuminuria. So here's another knowledge check. Which of the following SGLT2 inhibitors have been shown to reduce the risk of hospitalizations for heart failure? A, empagliflozin and canagliflozin. B, empagliflozin, canagliflozin, and dapagliflozin. C, canagliflozin, dapagliflozin, and ertugliflozin. D, empagliflozin, canagliflozin, dapagliflozin, ertugliflozin, and sotagliflozin. Okay. So it looks like the 60% majority has it. Well done. So the correct answer is empagliflozin, canagliflozin, and dapagliflozin. So those were our three. I'll just go back a couple slides that showed heart failure and renal benefit. So our next drug class that we're going to talk about today is the glucagon-like peptide receptor agonists, or GLP-1RA. So I have a picture on this slide of the Gila monster because the GLP-1 agonist actually was extracted from the Gila monster. So I thought that was a fun tidbit. Okay. And it was actually used to create the one of the first GLP-1 agonists, Byetta. So these are GLP-1 is a peptide that's endogenously released from our intestines following a meal. It acts on GLP-1 receptors on the pancreatic beta cells to cause the release of insulin and amylin, which promotes satiety. It reduces glucagon from the alpha cells of the pancreas, so we have less gluconeogenesis and less glycogenolysis, and it slows gastric emptying rate. So it seems like a great drug. So GLP-1's mechanism of action is it's really diminished in diabetes, and it does have a relatively short half-life of 1.5 to 2 minutes, because it's usually metabolized by this DPP-4 metabolite, which is why we have DPP-4 inhibitors to prevent that. But really what we see is what I explained on the previous slide. When you have a GLP-1 agonist bind to this receptor, it stimulates release of insulin and amylin. So we have insulin that's going to help break down our blood sugar, and we have amylin, which is going to help promote satiety. And I'm sure you've all likely heard by now this ominous octet of all of the ways that GLP-1 affects different organ systems in our body. One of the biggest things that we see is we just talked about increasing insulin secretion. There's also decreasing glucagon secretion, so therefore less gluconeogenesis and glycogenolysis, increasing blood sugar. We also see decreased gastric emptying, increased acid secretion, decreased GI motility, decreased appetite, increased satiety. We see decreased blood pressure, increased natriuresis, increased glycogen synthesis, which is great because that means we're pulling blood sugar out of the blood into the muscles. And then also lipolysis, free fatty acid synthesis, glucose uptake, and hepatic glucose production. So lots of great things that our GLP-1 agonists do. So here's a similar chart detailing all of the clinical trials as well as the currently available GLP-1 receptor agonists on the market and their cardiovascular, heart failure, and renal benefits. So our first drug that we look at is exenatide, and it was non-inferior compared to placebo for 3-point MACE. So again, that 3-point MACE is death from cardiovascular cause, non-fatal MI, and non-fatal stroke. And there was no significant difference for all of these drugs in risk of hospitalizations for heart failure. And there were no reported renal benefits from this exenatide trial. So for liraglutide, we saw a decreased risk of that 3-point MACE outcome, and we saw a decreased risk of composite renal and retinopathy outcome. In the semaglutide subcutaneous trial, we saw a decreased risk of both 3- and 4-point MACE. And so with 4-point MACE, we add hospitalization for unstable angina and heart failure. For renal benefit, we see a decreased risk of new or worsening nephropathy. For lixisenatide, it was considered non-inferior compared to placebo for 3-point MACE. No renal benefits reported. For the oral semaglutide, it was non-inferior compared to placebo for 3-point MACE, and again, didn't look at renal benefit. Dulaglutide had decreased risk of 3-point MACE and decreased risk of renal disease. And so it's really important to take a look at these and see, okay, so this one, these 3 have cardiovascular benefit potentially, and these 3 have renal benefit. That's been statistically significant. Okay, so this chart is another one that's really small and hard to read on this screen, but I think you'll be able to see it when you take a look at the ADA guidelines. It's more meant to make you aware of its availability. And so this is a really great chart. I only copied the first half of it, or the top part of it, with metformin, SGLT2 inhibitors, and GLP-1 receptor agonists. And really what we see here is we see how is the efficacy in treating type 2 diabetes? How about the risk of hypoglycemia? Is there a risk? Is there a risk for weight change? So in SGLT2 inhibitors and GLP-1 receptor agonists, we see weight loss, which is great. But I think based on what your patient's comorbidities, risk factors, concerns are, you can easily use this table to help you identify what would be the best therapy for them. So something to also consider is for cardiovascular effects. So we can see for the SGLT2 inhibitors, there's a benefit for empagliflozin and canagliflozin for patients with ASCVD. And then for GLP-1 receptor agonists, we can see that there's a benefit down here with dulaglutide, liraglutide, and semaglutide. Then if we go to heart failure, we can see that there's a benefit in SGLT2 inhibitors from epagliflozin, canagliflozin, and dapagliflozin. And we saw all of that information presented in the study tables. And we also saw that for GLP-1 receptor agonists, there were no differences in heart failure outcomes. Looking at costs, the costs of the SGLT2 inhibitors and GLP-1 receptor antagonists are still pretty high. It tells about, is the medication oral? Is it subcutaneous? If your patient has progression of diabetic kidney disease, or are there any dosing use considerations for patients with renal dysfunction? You can see that for SGLT2 inhibitors, we saw benefit in canagliflozin, and empagliflozin, and dapagliflozin. And then in GLP-1 RAs, we saw benefit on renal endpoints in the cardiovascular outcome trials driven by albuminuria outcomes. So liraglutide, semaglutide, and dulaglutide. And if you think about this statement, when we went back to our ADA guidelines, the CKD section, it really said if the patient has albuminuria, then we should be recommending an SGLT2 with outcomes, with positive renal outcomes. Looking at dosing use considerations, so really there is a renal dose adjustment required for quite a few of the SGLT2 inhibitors. Metformin, we know there are also some renal function concerns. There's also concerns as well for some of our GLP-1 receptor agonists, but no dose adjustments for dulaglutide, liraglutide, and semaglutide. Okay, and then there's a nice additional consideration section as well that I really like, because it helps you summarize some of the most important side effects for your patient. So letting them know with metformin, of course, that they could potentially get nausea and diarrhea. Don't necessarily need to counsel them on this, but being aware that metformin could potentially cause B12 deficiency. For the SGLT2 inhibitors, it is important to ensure that they're discontinued before surgery. Be aware of the DKA risk, that canagliflozin might have a slightly increased risk of bone fractures, genitourinary infections, risk of volume depletion or hypotension, because again, you're kind of pulling a lot of sugar as well as some water into the urine, so lowering blood pressure, and a potential increase of LDL cholesterol, as well as Fournier's gangrene, which is really because of those genitourinary infections. Again, because sugar can help bacteria breed. So there is for GLP-1 receptor agonists a black box warning of the risk of thyroid C-cell tumors in rodents, but again, we haven't seen relevance in humans yet. For liraglutide, albiglutide, dulaglutide, exenatide, and extended release, and semaglutide. GI side effects are common, so most of our patients starting on GLP-1 RAs are likely going to experience nausea, vomiting, and diarrhea. Injection site reactions could potentially happen, and the importance of watching out for pancreatitis and discontinuing if it is suspected. So I know that was a lot, but I think there's so much great information packed into that table. So let's do a quick knowledge check. Which of the following SGLT2 inhibitors have been shown to reduce the risk of MACE and albuminuria? So liraglutide and dulaglutide, subcutaneous semaglutide and oral semaglutide, liraglutide, subcutaneous semaglutide and dulaglutide, dulaglutide, subcutaneous semaglutide and oral semaglutide, or exenatide and lixisenatide. Okay, so the 43% got it right. So the answer is liraglutide, subcutaneous semaglutide, and dulaglutide. So let's get back to our patient, patient LS. So I want to make sure I jog your memory by pulling out some key important facts about this patient. So the patient has reduced ejection fraction, heart failure, with an LVEF of 40%. They have uncontrolled type 2 diabetes. They're currently only taking metformin for their diabetes. And then there's been no medication changes in the past month, and that A1C goal is 7%. These are the vitals, still within normal limits. These are the labs we went over before. Again, A1C is 8.5, still quite elevated. We have impaired renal function as well as albuminuria. So here's another knowledge check. So thinking about our patient and all of the guidelines that we reviewed, what is the best next step for our patient LS? A, offer congratulations on his progress for lowering his A1C by 1 full point since metformin initiation, dietary adjustments, and increased exercise. Tell him to keep up the great work. Use shared decision-making to discuss the risks and benefits of initiating an SGLT2 inhibitor like empagliflozin. Discharge the patient from further follow-up with the pharmacist as his A1C is now less than 9%, or D, A, and B. Great, the 71% A and B's have it. So it's so important to encourage your patients and congratulate them on their successes. Even though our patient may not necessarily be at goal yet, they've still made significant progress just with metformin and exercise and lifestyle adjustments. It's really impressive that they were able to reduce their A1C as much as they did. It is important to use shared decision-making to discuss those risks and benefits of initiating an SGLT2 inhibitor like empagliflozin, and especially in patients where there are a lot of, or quite a few different disease states that would benefit from it. We don't want to discharge our patient from further follow-up with the pharmacist, as his A1C is now less than 9%. While that is the CMS guidance for considered uncontrolled diabetes, we do want to make sure, because our patient's still relatively young, he's only 55 years old. And again, the point of treating our diabetes is to help to prevent some of these microvascular and macrovascular complications, to help our patients live long, happy, and healthy lives. So a patient who's maybe in their late 80s, early 80s, who has been on metformin or who has been trying to control their diabetes for a long time, a goal of less than 9% might be reasonable. But for a patient who's 55 and we want him to live a good 45 or so more years, ideally, really we want to have more strict control. And that's the recommendation of the ADA guidelines as well. So just going back to our guideline to help us remember why we would want to start that SGLT2 inhibitor. So our patient has heart failure. Our patient's LVEF is 40%, so it's less than 45%. So we want to start an SGLT2 inhibitor with proven benefit in this patient population, and empagliflozin is one of them. It's also the medication preferred by the CT Medicaid. Our patient also has CKD. And so for patients with CKD who have albuminuria, like ours does, because their microalbumin creatinine ratio is greater than 30, we would preferably start a SGLT2 with primary evidence in reducing CKD progression. And I think this is another image that kind of further emphasizes, yes, we do want to also, per the KDIGO 2020 guidelines, not just the ADA guidelines, we would want to start an SGLT2 inhibitor. So here's another knowledge check. Which of the following laboratory values should be routinely monitored for LS? Vitamin B12, BNP, A1C, or all of the above? Excellent, 88% with all of the above. So vitamin B12, we want to monitor because metformin can lead to vitamin B12 deficiency. And although our patient is already taking 1,000 milligrams of B12 every day, sometimes metformin can contribute, it's theorized, to decreased oral absorption of vitamin B12. So even with vitamin B12 supplementation orally, sometimes it's important to check that B12 level, especially to ensure that injectable therapy isn't warranted if the absorption is not appropriate of B12. So 3 months later, let's check in with LS and see how he's doing. See how the SGLT2 inhibitor and metformin combination are treating him. So it looks like his A1C has come down from 8.5 and is now 7.6, which with an SGLT2, that's a really great decrease. It looks like his renal function is about the same, eGFR about the same, blood glucose did come down quite a bit, and uromicroalbumin creatinine ratio is still about the same. So given that information and what we've reviewed in the guidelines so far, what is the next best step for LS? Do we want to A, add on a GLP-1 agonist with demonstrated cardiovascular benefit, such as liraglutide, B, continue current therapies and recheck A1C in another 3 months, C, initiate basal insulin, or A and C? And as a reminder, our A1C goal is less than 7%, and his A1C is currently at 7.6%. Okay, so for this one, our patient their A1C was 7.6. Let's see. So their A1C was 7.6. So the correct answer is add on a GLP-1 agonist with demonstrated cardiovascular benefits such as liraglutide. I think that we can achieve sufficient A1C lowering with the GLP-1 agonist, as you often see 1 to 1.5% A1C lowering, bringing him below that 7.0% goal that we wouldn't necessarily need to initiate basal insulin, which I think is quite a relief in our obese patient who doesn't want to have any more weight gain. And we know that insulin can cause significant weight gain. And we certainly don't want to continue current therapies and recheck A1C in another 3 months. So I'm glad that that was not a popular choice. Okay. So for this last portion of the presentation, I wanted to talk a little bit about type 2 diabetes during COVID-19 and how the pandemic was both helpful and harmful in our patient population for type 2 diabetes. And at the end of the presentation, I'm really interested in hearing, please feel free to enter into the chat if you had any other considerations for how the pandemic affected type 2 diabetes, because this is something really interesting for me. So COVID-19 infection and diabetes, why are we concerned about these patients more so than some other patients? So some of the complications of diabetes, including cardiovascular disease, heart failure, and CKD, can increase the risk of COVID-19 related mortality. Some of the links between COVID-19 and diabetes include effects on inflammation, glucose homeostasis, altered immune status, and activation of the renin-angiotensin-aldosterone system. So if you think about it, when patients get sick in general, we know that there's going to be kind of a fluctuation in their blood sugar levels because their body is really stressed and trying to heal itself and likely using more energy than usual. So in addition to the negative effects of COVID-19, that can all add up. So how can we prepare? We can help our patients to maintain tight control of glucose levels and prevent complications that are associated in order to prevent more severe courses of COVID-19. So we can prepare and share a sick day plan to avoid hypoglycemic events. We can encourage patients to maintain fluid and electrolyte intake if they are infected, and instruct them when to seek medical care. So that's all really important. Some additional challenges that are associated with the COVID-19 pandemic for patients with diabetes, and I don't necessarily think that this is restricted to patients with type 2 diabetes. I think Nathan mentioned that I often am in a clinic treating patients or helping patients with adult cystic fibrosis. And these patients, along with patients with diabetes, had reductions in access to care, disruption in their usual exercise routines because maybe their gym closed, maybe they don't want to go to the gym because no one's wearing a mask, even though you're required to. There might be some component of depression or anxiety. I think a lot of us experienced that during the pandemic, not being sure what's going to happen next, being worried about the health of our friends and family members, especially those with chronic conditions like diabetes. Loss of employment. A lot of people lost their jobs in the pandemic, and thankfully there were unemployment benefits that could be utilized, but there were a lot of negative potential results from that loss of employment, such as food insecurity. We already know that eating healthy and being able to eat fruits and vegetables are so important to helping control blood sugar and control diabetes. Oftentimes, some of the cheapest foods to eat are instant noodles and pasta, and those are not so great for patients who are trying to control their carbohydrate intake. if they have diabetes. And it is so important for them to be eating fruits and vegetables, which are so much more expensive. So that's something that we worry about, or being able to afford food at all. A loss of electricity makes us concerned if patients can't afford their electricity bill and have to put their insulin in the refrigerator, or their GLP-1 agonist needs to be refrigerated and they lose power. If that's not able to remain refrigerated, that's a significant loss. And thankfully in Connecticut, and likely in other states, we have opportunities for clinicians to get involved and ensure that patients do retain access to electricity for refrigeration devices that are required for medication. Loss of employment can sometimes lead to homelessness, and not only not having a refrigerator, that increases your risks of contracting COVID-19. It often decreases your access to a secure source of food. Loss of income is something that kind of is encompassed in those above, but I think is a real fear was a real thing that happened to a lot of patients, as well as loss of insurance benefits. I'm sure you all know the exorbitant cost of insulin and GLP-1 agonists if you're paying out of pocket for those injectable medications. It's hundreds of dollars. And certainly there are some options that are available that are more generic or more affordable in MPH formulations, but are they always the best options for our patients? So there's a lot of things to think about, but I think this loss of employment, depression, anxiety, disruption in our exercise routines, and decreased access to patient care were big concerns that we had for our patients during this pandemic. So some of the opportunities that kind of came through the pandemic too, I like to look at not only kind of the challenges, but how we met those challenges and how we moved forward, being resilient and working through it. So we were able to improve access to care through use of telemedicine. So for patients, we received a significant increase in the number of referrals for our patients with diabetes and heart failure and quite a few other conditions, because clinicians were being pulled to go and cover inpatient units, that there was a high number of patients with COVID. So they had less availability to see patients in clinic. So we were really able to step in there and help improve access to patient care by opening up more pharmacist visits. Also using telemedicine to connect with patients either via phone or via video visit. And really, one of the things that this has opened up to us are now for almost all patients who are newly started on insulin or newly started on a high cost injectable medication therapy or something that's a little tricky to administer, once the patient goes to the pharmacy and picks up their medication, it's almost second nature for us to have them have a scheduled follow-up visit on video where they're able to demonstrate appropriate technique, give themselves that first injection with someone there encouraging them and coaching them that they're doing the right thing, because that can really help ease anxiety. I think it also helped telehealth become more mainstream. So patients were able to have more frequent follow-up. So when we're titrating patients' insulin, we can follow up with them once a week. We can follow up with them twice a week or every couple weeks. It doesn't necessarily have to be a burden where they have to come into clinic in order to receive care. So that's really something wonderful. Another thing that we were able to do, as I kind of alluded to, we had a lot of referrals for patients with diabetes particularly, but pharmacists got engaged in collaborative practice agreements where we were able to demonstrate how effective we could be at helping these patients achieve their A1C goals, even in such a stressful time. I think a lot of patients saw that there was more time to exercise when they were working from home. I know not having to get up and commute to work saves me about 30 minutes every day in the morning and in the afternoon. So why not turn that time into time to exercise? And then patients who frequently prepare meals at home versus eating at restaurants. So most of us know that when you prepare meals at home, you have the opportunity to control what goes in them naturally, but it's a lot easier to prepare healthy meals at home rather than eating out at a restaurant where there's likely a lot more fat and a lot more sodium and bigger portions as well. So I think some of these are the key opportunities, but I'd really like to hear from others about how how you used kind of, or what you learned from this pandemic in terms of how to make care for patients with type 2 diabetes even better. What were you able to do? Okay, so we're a little early in ending, but thank you so much for your participation in all of our polls. I wanted to make this session really interactive, and please feel free to enter any questions into the chat or into the Hugo platform.